a little quick list. The list goes very long, but a quick list of just kind of different diagnoses that pelvic floor muscle dysfunction looks like. Because a lot of times too, people are surprised that I'm looking at their abdominal wall. But again, it goes back to that whole system. They're working together. So we gotta look above as well. So incontinence, stress incontinence, urge incontinence. So stress incontinence is that incontinence from a stressor, from a physical stressor. So any downward abdominal pressure. So if you're doing like a bending movement or breath holding, that downward pressure, a cough, a sneeze, laughing, jump roping, trampolining, all those things, it's like it has impact to it. And how does your pelvic floor respond to that stressor or that impact? And then urge incontinence is more, you get a strong urge, you don't have much time, you have leakage on the way to the bathroom, and then mixed. A lot of times people have both. Overactive bladder, urgency, frequency. So you may not be having leakage, but you're going every 30 minutes, or every time you pull in the driveway, you have no time to get to the bathroom. You have that kind of learned urge rather than a true kind of full bladder urge. So being able to work through that. So that's a whole nother subset as well. So your bladder connects with your pelvic floor. When your bladder fills up, it stretches the lining, and that stretch is what creates a true urge. And then that urge, the pelvic floor says, I hear you, calm down, I need to get to the bathroom. And then they can communicate that way and calm each other down. But the bladder is also connected to your lumbar spine and your brainstem. So the brainstem is the tricky one, where it learns our habits. So if you start to get in the habit of doing just in case pees, going to the bathroom before you leave the house, even though you just went 10 minutes ago, but just in case, it starts to learn that. So instead of filling and stretching and giving the urge, it gets to halfway and says, she likes to go now, so I'm gonna give her that urge. And it's a true urge in the fact that you feel it and your body has generated it from what it's learned, but you're kind of a slave to it because you don't really have to go. So, but just, as our bladder learns our bad habits, we can retrain it and reset it to have the normal functioning habits as well. Takes a lot of work and dedication, but once you flip the switch, it goes back to its kind of natural functioning urge system. And then, so prolapse. So a lot of people think that, I have pelvic organ prolapse and I'm a failure because my muscles are just weak and I should have done more to prevent this. So a lot of times when people come to me with pelvic organ prolapse, they have the opposite. They have tight pelvic floor muscles. When you think about the organs that are being held in the bowl, they are not directly held up by the pelvic floor. The pelvic floor is below them, but they are not the actual structure holding them up. They are held up by connective tissue attached to the inside of the pelvis. And the pelvic floor is there to be a supportive unit for it. What happens with prolapse is the connective tissue has gotten stretched and now the organs have kind of moved into a space. And so what the pelvic floor does is it has more of a workload and it's working really hard to do its job. So it ends up often being more tight and contracted because it's overcompensating for now this kind of downward shift. So being able to manage the downward pressures better. So whatever it was that caused the prolapse, if it was childbirth or if it was just constipation chronically or just bad habits or constantly doing box jumps and holding your breath, being able to work through, because I've unfortunately had a lot of people who have had prolapse and then they had the surgery and then the surgery was undone because nobody taught them what caused the prolapse to begin with. So, in prolapse, you don't always have to have surgery either. there are steps to be able to manage the prolapse and to be able to manage your pressures and to strengthen and support around it. And if you can manage your symptoms, there's no harm in having a prolapse. It just depends on what feels comfortable and right for your body. So constipation. So this muscle here, if you can see, so this is the vaginal opening, this is the anus. So this muscle here is like a sling from the front to the back. And if you can imagine, if this muscle is tight, it's going to be difficult to lengthen to be able to void. So if you think of the rectum and that muscle is like a sling, it's kind of kinking it like that. So releasing that muscle and learning how to let go of it can allow for a better evacuation if you're experiencing constipation. Fecal incontinence, gas incontinence, and people just think that that's just how they are, but there could be some coordination issues or some tightness or some weakness going on that can manage that a little bit better. Pain. So you can see that the pelvic floor muscles connect right up to the tailbone and the sacral spine. And you can imagine if these pelvic floor muscles are tight, that they can be pulling on that low back or that SI joint in here and causing some trouble. Or maybe there's some trouble up here that's causing the pelvic floor to start to tighten up. So sometimes, trying to figure out the cause and effect, but more importantly, identifying it and working through it to be able to work through both systems. So sexual dysfunction, so just painful intercourse. Tight pelvic floor muscles are painful. So being able to work through the tightness and figure out what's causing the tightness, how can I release the tightness, how can you release the tightness or prevent the tightness from happening. And there's different techniques too. There's different dilators, there's different exercises and breathing exercises. For men, erectile dysfunction and premature ejaculation are all pelvic floor muscle related dysfunctions. There are other causes for them, but sometimes it could be pelvic floor muscle driven. I mean, if you look at the pelvic floor muscles for women and men, so this is a female, but the male, these muscles here just are connected. They don't have the hole. So women, we have more risk, we have the risk for prolapse because we have a hole in the middle of our trampoline, our supportive trampoline. Men don't have that, but these muscles are the same and they can get tight and they can get dysfunctional and they can cause sexual dysfunction as well. Or pain with sports, a lot of different sports pain or pain with ejaculation. And then diastasis. So lots of people have heard of that split down the middle of the abdominal wall. Being able to work with that because again, the pelvic floor and the transverse co-contract. They work as a team to support these open spaces in the pelvis. Okay, and the transverse is the tool to be able to support those muscle bellies who have separated and to be able to start to draw them in and down rather than allowing them to kind of just not be able to come back together and to like have our abdominal pressures push forward.